All right, I'm going to get us started here. I know everybody's going to filter in and get food. I'm Jürgen Münzer. I chair the Department of Psychiatry and Behavioral Sciences, and it's my great pleasure today to welcome a very special Grand Round speaker who's coming up here, Dr. Carlos Pellegrini. Carlos is our former chair of the Department of Surgery and now our first and our best chief medical officer ever for UW Medicine. An amazing guy, has been a tremendous role model for me as a new chair, but in his current role, and what he's going to talk about today is he is about transforming our healthcare system so that we can become accountable, not just for the people who sit in our waiting rooms, but for everybody who we serve as a population. And that turns out to be a huge challenge. And the good news is Carlos knows a lot about a lot of things. He knows about operations, not only in the operating room, but operations in a broader sense. He knows about aviation. He knows about a whole bunch of things. He also knows a lot about people. I actually think Carlos would have made a pretty good psychiatrist. So I'm very happy to have him here to help us with our psychiatry grand rounds. And I will make one other brief introduction. Carlos will be followed by our own Denise Cheng, who is going to talk about how we here in psychiatry are trying to take some of the ideas that we need to think about to try to not reach those in our waiting rooms, but to really reach a population, and how we apply that and how we care for depression. And when Denise comes up, you'll see I'm very happy to see her here giving this talk today, and you'll see that we're very serious in this department about our future. Carlos, thank you.
Thank you.
Thank you, Jürgen, very much. It's a pleasure to be here, because I'm learning. I try to learn every time I do something like this. First of all, I've never given grand rounds to a group of distinguished people in a department on a topic as dry as I was supposed to give a topic. But I was lucky enough that Denise was the one that initially made the contact with me, and we decided that what we were going to do is I'll tell you a little bit about what our office should be doing, and Denise will tell you how it works, because she's taken very seriously what I will try to chat with you a little bit during the first part of the rounds, and taking it into action. I'm learning another thing. As a chair of the department for 23 years, I used just the whip to say to people, you must come to grand rounds. You must come to grand rounds. And it only took me 1 minute when I entered the door and I said, oh my God. I thought I was going to speak to the regular grand rounds crowd, right? 8 people, 7 people, the chair and 3 people or something. And those excuses that, well, you know, the room is kind of empty, but there's room here in the front. There's room in the front. You can come over here. But I come here to a packed room, and of course, my ego, and you guys know a lot about ego, my ego tells me these people are really here for me. And I know differently. I should have just bought lunch for my people. Never thought about that. Well, anyways, thank you for having me, and I'm going to tell you a little bit about why the office was set up. Why did I choose to be there? And I chose to be in this office when it was set up with the idea of becoming essentially an enabler of healthcare. It's a very sort of aspirational thing, I understand. But, you know, to the extent that our office can be seen as a trusted source for clinical solutions, Denise will show you what the clinical solutions are. A convener, consensus builder, wayfinder, a little bit of a catalyst in terms of clinical education and research activities, and obviously a student of the evidence that would make my parting time at UW more fun. I had been at UW for 24 years as chair of surgery, and I was thinking about departing, period, but this gave me an opportunity to sort of refine myself in another way. These are the statements taken from my position description. So the CMO is supposed to do coordination of clinical care delivery across the entire system. We have 4 hospitals, the medical school, the practice plan, the neighborhood clinics, the Airlift Northwest, to working in the integration of clinical delivery with education and research. To do transformational care, we'll get back to that in just a minute, and to do strategy setting at UW Medicine. And a lot of people ask me about transformational care and what it means for me. So if I have to give you the relatively simple explanation of what it means to me, it means to me moving from the traditional care, one in which we have facilities as you have across the street here, you have providers as you're here, then you had patients that were outside in the universe needing some kind of service, and we provided services via the providers or the facilities or both, and then we got paid for any service that we provided on the basis of time, on the basis of effort, on the basis of whatever, but we got paid every time we provided a service. To a situation where the patient is at the center, we look at patient-centered care as the major element here, and where we pursue the triple aim as defined by Don Berwick and now over 12 or 13 years ago, as a better experience of care for the patients, as a better health for the population, and some form of a lower cost, which is a mighty thing to pursue, because as it has been shown over the last 2, 3, 4 years, decreasing the cost is probably impossible if you want to do 1 and 2 as listed there. And probably all we can do at the moment is decrease the rate of increase of cost of medicine as opposed to simply decreasing the cost. Why change it? Because there was a sense socially that, from the doctor's perspective, we were experts trying to deliver the best care that we can, for the most part, heavily specialized people. From the payer's perspective, on the other hand, it appeared to be a not so coordinated, ineffective, and inefficient care. And from the patient's perspective, it was pretty much the same. How many of you, I shouldn't ask that because that's a HIPAA, I guess, violation, but how many of you want to tell the rest of the people that you have been a patient and sought care somewhere? As a patient, not as just I have been one. And if you have been there, you realize what coordination of care means. If you have been in the care of specialists, as I have been, wonderful individuals who saved my life, right? But if you have been in that situation and you realize that I had to talk to the doctor, to the surgeon, to the nurse, to the chemotherapy person, and the appointments are in different places and nobody seems to know what the other person just told me. Every time I go somewhere, I have to put my name again and my ID and show my insurance and sign all these disclosure papers. There isn't a sense that the system, and this is one of the greatest difficulties, is integrated enough. From the healthcare, from the employer's perspective, a significant cost and a focus on sick care, right? Rather than avoiding the sickness altogether. And a general recognition that if we're going to fix this, one potential way, and I say this because I don't think it's the only way, having now done this job for 18 months and 1 day, but if we're going to fix this, one potential way, Medicare saw it this way, is to say, we're not going to pay for services anymore like we did in the traditional care, right? You do some work, you put some effort, then we pay you something, but we're going to pay for value. If you deliver value, you get paid. If you don't deliver value, you don't get paid. And it's something that in the industry in general, it appears to work. So it's the volume to value. So what is value? Value is then defined around the customer needs, around the patient's need, and depends on results, not on inputs, not on volume, not necessarily on processes, but the rewards have to be how is the patient seeing the value that we provide. And this is a very important aspect that in my position now I get to see a lot, and I never saw it before. Frankly, as a surgeon who treated cancer and as a patient who had cancer myself, I see value as living and being able to stand in front of you today, 17 years after I got my operation, and say, look, despite my own smoking and all the other things, I survived and I'm here. That's not what most patients see value. Value is equated to empathy. Value is equated to compassion. Value is equated to ease of appointments, to the feeling and the sense that there's a coordinated care, to a whole lot of things that when sometimes people, and I get that one a day, complain to my office about something, they complain about what they perceive as value. And I stop and I think, can you realize how privileged some of us have been by having the best surgeon, the best chemotherapy, the best everything that allows you to be here, right? In the case of cancer, it's pretty easy to define. But that's not what most people see as value. So value, that's what value. And value is the difference between outcomes and cost, or the ratio between outcomes and cost. And outcomes now are the health circumstances that are most relevant to patients. So in my field of surgery, a great outcome, believe it or not, was the way the wound was closed and the way the wound looked after we had closed it. And that is usually the part that we leave to the intern, right? Because we were trying to teach people on the one hand, and because frankly, after you had removed the big tumor and connected everything and done everything perfect, that was the least in our minds important, but that is a big thing on the patient. Cover near and long-term health of the patient, include sufficient measurement of risk factors to get risk adjustment, experience of care, etc. So that is what the outcome is from the patient's perspective, and the cost refers to the full cycle of care given to a condition. So again, I used to think of cost as the cost represented by an operation that I did or a visit that I did, right? Well, cost is a lot more than that. Cost is taking the day off from work to come here, having to park to come here, having to disrupt the normal series of circumstances, childcare and school that you have, and a number of other things. So almost everything that surrounds the treatment of a disease is cost. So the vision for transforming care in this world where we were going to be reimbursed by value, and that would be in the outcomes versus cost, is that we can show all stakeholders, patients, payers, providers, that everything we offer, from prevention of disease to end-of-life services, goes to the right people, the right time, the right place, and the right team members with the right outcomes at the right price, right? And that is the total order that I was talking about. And we intend to do that by changing, slowly as we're changing, the organization to be a more high reliability organization, to follow the principles of high reliability science. And that, in a nutshell, is the type of science that drives nuclear power plants, zoos, entertainment parks, aviation, a lot of things where there's a fair amount of risk if something goes wrong, but then it doesn't go wrong. So the permission for error is on the 0.00001 rather than our permission for error. I remember writing papers saying, with a 10% mortality, this paper shows this operation is safe. In my mind, I was saying 90% survive, right? Well, 10% is totally unacceptable in the high reliability science. And moving from volume to value, as we just discussed. And we decided in our office that in this transition, where we still pay for fee-for-service a lot, and we are transitioning to value in a relatively slow pace, that there were 6 initiatives that we wanted to do to move forward. One was standardization, and standardization of everything, what you do and what we do in surgery. It's the same thing, standardization of processes, standardization, because standardization then allows on the edges of that for coordination of care around that standard process. Everybody, the nurse, the student, the resident, yourself, knows that this is the way Dr. A and Dr. B and Dr. C and Dr. D see patients, establish schedules, et cetera, and can therefore do a better coordination. Denise is going to talk about this point, populations as well as patients. So for many, many years, we just sat there waiting for a patient and took one patient at a time. We now look at an entire population, an entire panel that goes to primary care with 1,500 patients. And we say, let's filter that and see how many of these patients have had the PHQ-9 done, how many of these patients are depressed, how many of these depressed patients are taking medication, how many have filled up their prescriptions. how many are supposed to come back and have not come back? Do we call those people? That requires a team that we get through a medical home, which is the other portion of our instinct here, so that we can provide that coordinated care that extends not to the person that you're seeing today, but to the ones that you are not seeing, because they didn't come back, because their depression got worse, because they didn't take the medication, because they couldn't take the medication, because they had an allergic reaction, because the dog ate it, whatever. To do better use of data in the pursuit of this evidence base that I told you before, but to also add patient-related outcomes to that. That is to base a lot of what we say outcome based on the patient that came there. So you got back pain, you get an operation here in the spine. We used to look at fusion. If you have fusion, that's a good result. That's what the surgeon intended to do between L4 and L5. Well, now we're switching to say, if you still have pain, then the result is bad, whether fusion is there or not. To do healthy care as well as sick care. So to concentrate on keeping people healthy as much as we can, to make use of wearables, and you here in this department have been champions at a lot of research in this area, and to then introduce whatever we introduce, a process, a device, a new machine, a CT scanner, whatever, after a little bit of a thorough analysis to say, is this innovation going to give us a good result or not? So when you standardize, you can see on this quick overview here, you get better results. This is a great standardization that was done for ventricular assist devices that are very complex type of operations that you put on someone with heart failure. And you can see that whether you look at observed versus expected length of stay, or ICU care, or readmission rate, or mortality, that all the numbers do better. And so let me briefly switch as we prepare to hear a little bit from Denise. One of the programs that we are most proud of. When I took this office, within a month, we started to say, and this was the idea of David Flum, who's Pierre's friend here. David said, you know what we should do? Instead of having a top-down, instead of having a professor talk to people, let's have a grassroots effort. Let's try to recruit young people, young at heart. I mean, people that have an interest in doing new things, that are not afraid of change. That let's give them a challenge. Let's make their life meaningful, and create a program that we will call the Clinical Innovators Program. And the purpose was to have clinicians and clinician leaders participate more effectively in the design, surveillance, and optimization of the system, and to raise expectations of them as members of UW Medicine. So we wanted to engage people. We wanted to put on them the expectation that if you get to this job, that we expect something to come up from that. So I don't think that these elements here are important. We wanted to have engagement associated with expectations, as I said, extended everywhere. And the idea was to fundamentally rethink the role of clinical faculty as people that are key to the progress of medicine, to this transformation from what we were to what we are, participating in the designs of new ways of delivering care, and you'll hear a little bit about that, embrace the principles of high reliability science that I told you before, measure the results of their efforts, optimize performance, and move forward with that. We ask that everybody try to get, this is like injecting a virus in those computers, like the WannaCry that you saw that made such a big splash. But we would like to make it contagious so that those people, like Denise, who's involved in this, gets enthusiasm from others. And you look at every place where we can contain costs, for example, whether it's pharmacy or supply chain or whatever, that we do it. And move from, as I said earlier, from case management to population management by doing all the things that I listed here. And obviously all these slides are available to you. They're in this computer and they can be available and they can use it. And I would love it if any one of you uses the slides and figures it out a way to pass this message to others, right? We also had expectations of leaders like Jürgen, like many of you who are in this room. And that is to provide strategic and operational leadership in the system design, in the measurement and the management to provide the best infrastructure, training programs, to create an incentive and workflow alignment, and to support this as a learning system, a culture that fosters innovation and supports research and our training mission. You know, a learning system is a system that prides itself to make use of every mistake that we make to become better. And so the ability to talk about threats in the environment, the ability to talk about freely about errors that we have made and what we learn from errors is the key to that. So what I'm asking for you today, before I leave the stage here, is to promote the development of pathways. That standardization clue is what is going to drive most of the activities this year. On anything that you do, if you can create ways in which you and your partner standardize the care and the process of care, whether it's the way you schedule patients in the clinic, the timings that are spent with patients. We have such a disarray of, you know, we have something like 290 clinics, and every clinic is completely different. But the most important thing is that within a clinic that has only one nurse or PCC or whatever, there are 3 providers or 5 providers, and each one of them has a different way of scheduling and doing things. To strengthen the behavioral program within the UW, this is a creation of you here on this department. This is now not nationally, it's worldwide recognized as a key issue here. And I think it is fundamental that we strengthen that because of all the value that you know that has that. And to promote the grassroots exchange, we are in the process of, within days, of recruiting the new class of CPIs. We had 300 people join us on the first year. We want to recruit the new class, even though before we started, we have about 150 people that have approached and said they wanted a new sort of class of CPIs. We tried to get these people to provide them with tools. We need them to bring only one thing to us, that is energy and fire in the belly. And then we will provide them with tools that will then sort of free their mind to do whatever project is germane to them and to their specialty and bring it in there. And as I was thinking about recruiting, I said, you're a psychiatrist and you know this, there are different ways to approach people to recruit somebody to do something, right? And I love this recruitment tool that was used in 1914 by Shackelford when he was going to go on his trip to Antarctica. Men wanted for hazardous journey, small wages, bitter cold, long months of complete darkness, constant danger, safe return doubtful, honor and recognition in case of success. And that was then. But as Jürgen told you, I have been involved in aviation all my life, and I like one of the companies. I was with a pilot one day flying just on the side of him and checking him out, and I noticed that he had on the back of his iPad, you know, they used to carry all these books, now they carry little iPads. He had sentences on the back of the iPad. And then I saw that another crew member, a flight attendant, had the same sentence on the back of the iPad. And I said, is this something mandated by the company? Absolutely. The company gives you the iPad, and that's inscripted on the iPad. And it's a small company that flies VIP jets kind of thing. But look at what they say and compare that with Shackelford thing. Serve from the heart, love what you do, improve something today, seek first to understand, deliver on commitments, make the most of what you have, keep calm, ask for help, make mistakes valuable, and have fun. So with that being said, I want you to help me recruit the new class. I want you to tell your friends, and as I said, use these slides or whatever other mechanism you want to recruit them. And let's see if this works. Denise was a product of the 2016 class. And so I'm asking you to now come on and perhaps give your talk. Thank you for your attention.